Cioffredi, our founder and CEO, and he'll be speaking on the foot this evening.
See how the audio-visual goes here, since my notes not showing up on my screen, so I might flip through some pages. So this is a photo about children. So Ruth and I have four wonderful children, and I always thought that having children was the important part of it, so that they could help do the chores around the house. Seeing as how I still mow the lawn, that never seemed to work out. But our third oldest daughter had the opportunity to study in Spain this past semester, so Ruth and I had to go over to make sure she wasn't too homesick. And this is a picture, this is southern Spain, this is Granada, looking over the city, and some of the old section of the city and the fortress and the Sierra Nevadas in the background. So, beautiful place to go. And fortunately we had some children to get us over there. So we'll talk about the painful conditions of the foot, common but sometimes misunderstood. So in a small period of time, my interest is to put a little bit of focus on some issues that might be different than the normal things that we can all find out about. So I'm just going to talk about the non-traumatic conditions. So non-traumatic means that these painful problems didn't come on by someone wrenching their ankle or suddenly jamming their foot, jamming their toe. That's not under this section. These are the ones that are kind of gradually come on. They gradually show up for the most part. At least there's not an incident or an event associated with it. So we'll talk primarily about Achilles tendon problems. So tendinopathy is a fancy term. We're beginning to change some of the nomenclature about things, but the Achilles tendon and the Achilles tendon region, and plantar fasciitis, which is another term for pain around the heel or the arch, and if we have time at the end, metatarsalgia, a fancy term for pain around the ball of the foot. So just the goals tonight would be to maybe, if you come away understanding something a little bit different or a little bit new about some of these very common pain problems, and some understanding of, some things can be done about it, then I think that we've achieved something tonight on this subject here. So with all these things, there's causes that are common to all of them, and because they're not traumatic, excessive loading, usually over sustained periods of time, but it can be shorter, and the excessive is it's bolded because excessive is all relative to different people and different activities. So what's really excessive to one person might be not a problem at all to somebody else. So relatively long, repeated periods of standing, walking, or running. Again, relatively, because it's going to vary from each person. So increased intensity of activity, standing, walking, running on relatively hard surfaces. So if we have somebody who's they've been working behind a desk at one of the great industries on Etna Road here, and then they get shifted to a different job where they're running on the floor, and they're standing, the floor is concrete floor, tile on top of it. Body's not used to it, so that transition to a harder surface can really be quite a difference. That is some of the thing that precipitates that kind of a problem. Wearing hard sole or stiffer shoes can be an element that contributes, so or almost no shoes. So we have people that might have to wear steel-toed shoes in some of their work, and that may have some influence on it. We may have younger kids during the summer, or actually during the winter, some of them who wear really thin flip-flops that are actually the opposite, where there's really no support, it's very thin. And aggravated by abnormal biomechanics, which is part of what we'll put some focus on. going back to the relatively long, excessive loading, you'll have somebody who may be a runner who is used to running 3 miles at a time, and they run three days a week. And so for them, excessive activity may have to be, they maybe have to add on, oh yeah, I was doing some really long distance stuff like running my 10 miles because I'm training for a marathon, and I added on this extra miles on the weekends. And so that might be what's relative to them. Somebody else, it may be, their exercise might be, oh, I like to cycle, or I like to exercise in the water. I do water aerobics or something. But on the weekend, I went with my husband and down to Boston and spent the whole day in high heels on the hard surface for the day. And that's quite a difference. And that's the relativity of it. So, for those of us that have been around a while, as I kind of alluded to days before the web, there wasn't access to so much information, but now, for a lot of these common things, you can all look up on the web and instantly find out, oh, well, what are the things you do for Achilles tendonitis, or what do you do for plantar fasciitis? And so there's a barrage of stuff that's there, and it's all good information from the standpoint of very common things that are used, easy to access. So what we're talking about tonight are those things that they don't tend to go away in a few days or a week, or after a couple of weeks, if your homemade treatments or the information you got on the web, things aren't going away, then they're really persisting and they're not responding. And that's a little bit of where I want to put a little bit of focus tonight, and hopefully we get some other information about that. But there's also those folks that may have had some treatment and these kind of problems persist, because as you see on the web, some of the problems like plantar fasciitis are, yes, they can last for months. And I think that the point tonight would be with some of those folks that it lasts for a long time, maybe because the treatment wasn't really that well targeted. So treatment's really most effective when the diagnosis is specific and accurate. So diagnosis we use as consider a physical therapy diagnosis from the standpoint of understanding the biomechanical aspects and what other components really created the situation. So once you get past the people that they get better on their own in a week or so, you have all the rest of us that are like, hey, this thing is not going away. For those folks, the really important parts are a really individualized treatment, as opposed to the shotgun approach that you can look up on the web and see, well, try this, this stretch, this boot, that thing, this shoe. As Dr. Nutting mentioned about his story, when he said when somebody comes in to see him, he doesn't look at all the other stuff, he takes the story from the beginning. That's the very same thing for us here, whether it's about a foot problem or any other problem. It's the story that goes along with how this thing came on is very important. So it's the expertise of the clinician that really gets the information and asks the specific questions and the detailed questions that get the other details about really, well, what's really going on with this person to understand it best. And then a thorough examination, because just because you have pain in a certain area, that doesn't mean that that's right where the problem is. That's for all those people that get better really quickly, great, but the ones that don't, that's part of the hang-up. So understanding two components, really, for the source of the pain, we'll call it the pain generators or the sensitive tissue. So on one hand, you have the thing that's really sore to the touch, or where it feels like it's coming out of. And then you have, well, what caused that? Because it doesn't necessarily mean that where it's sore and it's hurting right now is the mechanical thing that really caused it. So that's the two elements we really want to understand. So some of the reasons things don't always respond to certain kinds of care or treatment. I have addressed only those things that contribute to the problem, and it's big capital letters only, not because I want to create fear about, oh, you might do something wrong, but it is the issue that for the ones that don't get better, if you use the shotgun approach and you look up on the web and there's the 3 top exercises to do, in some cases, some of the exercise, if it's the wrong condition, you're actually going to perpetuate the problem. And you could exacerbate it. You're not likely to cause any real injury, but it may be the thing that just keeps it from getting better or makes it hurt a little bit more because it's not really the right thing for the problem. Treat things in the right sequence, meaning, so if a woman who goes to Boston for the day, she's had no problem in her foot at all, but then at the end of the day in Boston, in high heels, walking the pavement, going to the museum, and comes home after 16 hours, and the next day her heel is killing her. That's a very acute, sudden onset, even though it wasn't an event in the sense of a trauma. And that is a condition that has a lot of inflammation in it, as opposed to something you really didn't even remember. When did it first start? But it kind of gradually got worse and gradually got worse. And like my wife here, who came and talked to me about, Bill, you know, my Achilles tendon's been bothering me, and it's really hampering me now. It's affecting me for my running. I said, well, how long have you had it? Well, about 6 months. So there is a much more chronic condition, and so treating things appropriately in the right sequence is important too. And then treating the right magnitude. So one of the questions about the shoulder previously was, if your arm hurts to raise it up, what do you do to keep it from getting stiff? And that was a great question. And so there's an example where, hey, if you were using your other hand to kind of assist and take some of the load off so you could make your arm work and it didn't hurt, but you were still moving, that would be one example of very light and low-grade exercise. It might be very appropriate for that at that time. But then as that condition started to heal up and it wasn't painful, then you might want to start strengthening those muscles, especially the ones that were weak in that. And so the issue of the magnitude as it relates to the foot would be similar in that there are some movements that would help enhance the healing, and some movements that would cause some stretching and lengthening of tissue, which might be very appropriate in a long-standing chronic case. And yet the woman who just came back from Boston, not that I want to hear about Boston, but that person, if they were starting to do their stretch that was highlighted in the thing to do, might really set their foot off, and what could have gotten better maybe in a few days now is going on a few weeks because they're really aggravating it or keeping it going because the wrong magnitude for the situation. So there's a bunch of treatments that are also common to the whole variety of painful conditions that we talk about tonight. So medications are a common thing you'll see on the web. And great question about the anti-inflammatory medications, NSAIDs, non-steroidal anti-inflammatory drugs. And so you heard Dr. Nutting indicate, hey, there's a place for that. And the example of the woman who, no problem with her foot at all, and then suddenly after being on her feet all day in shoes she's not used to wearing, then has a very inflamed tendon. The anti-inflammatory medication may be very helpful and very effective for that person taking it for a few days. Now, the person who might have something like my wife's condition in the sense of, oh, it's been bothering me for 6 months, we see that and we hear about those commonly in our clinic. It's been going on for a few months by the time people oftentimes come to us. So taking a non-steroidal medication regularly, like daily, like twice a day, or more, or even just daily. While this is not a seminar about drugs and nutrition and things, there is a lot more understanding out there about the effects of long-term use of anti-inflammatory medicine. In my younger years, I used to think about it as a lot. I had a big concern that you might have a bleeding ulcer or something because it would wear a hole in your stomach. Well, that's just one element. There's a lot of other things that, besides hay, can affect your liver in the sense of trying to detoxify the body, but also in our gut, where our immune system lives. Then we have problems with leaky gut syndrome and things where the nutrition, the absorption of nutrients in the body, it's not a great thing when you're necessarily, if you're on some of these medications for a long term, or they might even not be the right medication. If it's been a chronic problem, it's probably not really inflamed. It's painful, and you might be taking it for the pain reliever part of it, but it's really, there are some other aspects to that that might be questionable about taking that stuff regularly for a long, ongoing basis. Modalities to stimulate healing in these things. So commonly in our clinic we might use things like ultrasound, laser, certainly using ice, ice massage where you can take a Dixie cup and fill it with water and freeze it and then peel away the edge and just go over the skin for maybe 7 minutes. And that gets, the area gets red because it starts to rush blood into the area. So first it shuts the blood vessels down a little bit, but then it rushes blood to the area to bring in nutrients and oxygen and take out the waste products. So we use those things. Iontophoresis is a way of delivering medication with an electrical current. Is another thing that might look at trying to stimulate healing or reduce inflammation. The focus of really what we just want to highlight are correcting the faulty biomechanics, which really relates to a few different areas of supporting irritated tissue, loosening stiff muscles and loosening stiff joints, strengthening weak muscles once they're calmed down or when they're in the right state, and addressing any referred pain from muscle trigger points. So we'll just go over that as something that might be new or different. And it's the thing about the muscle trigger point pain problems are the things that are, right now they're not on the web. So at least if you look up WebMD and American Academy of Orthopaedic Surgery and some of the other really fundamental websites in medicine, when you look up Achilles tendonitis, it doesn't necessarily talk about muscle trigger points. So that's one element that might be new information tonight for you. There's also looking at addressing neuromuscular re-education, which is a big long term, which really relates to everything from, hey, if you can't balance very well on one leg, and sometimes that throws off the recruitment of certain muscle groups, to if you're a runner, do you really want to change your running form and running style to really address some problems that you're having related to your pain? That's not what we're really going to talk about tonight, but that's certainly one element that can be a consideration depending on the level of the problem. And then injections and surgery. So as Dr. Nutting mentioned about injections, the unique thing about the foot is that it's whole body weight bearing on your foot. So when you inject a steroid in an area that can weaken the structure, then it can contribute to a rupture of some of the tissue. So one of the nurses that I treated, she was having a painful condition. She knew she had a rupture because she had had the condition treated previous couple of years ago, and the injection resulted in a rupture of one of the tendons. And that's not really a fixable thing. It was, we're able to calm her condition down, so it wasn't painful, but this is not a person who was going to go on to really return to jogging or anything like that, because there was the lack of support is something that just is not really fixable. So injections, especially down in the leg and foot, carry some heavy weight to it from the injection. And surgery with these kind of conditions tends to be more of a salvage situation and not really a fixable thing like Dr. Nutting's situation where you really can get people who couldn't reach their arm over their head. Hey, he fixes them up and they can reach. This is a different story here. So as far as the area of what we're talking about, so the Achilles tendon is the end part of the muscle. This is the back of the foot, the heel as it comes down, and the tendon is the ropey end of muscles. So the big calf muscle comes down into the ropey end of the tendon, so it's a big, long, thick tendon. So this is the area that we're talking about. So Achilles tendonitis or tendinopathy, some potential sources of pain in the area of the Achilles tendon. Irritation to the Achilles tendon itself, which can be inflamed, like the person who went to Boston in the high heels and really inflamed the tendon. And then the person who just repetitively used their foot in running, where instead of getting inflamed, the chronic condition over time becomes a thickened tissue, so that the tendon actually changes on a cellular level, and the tissue becomes thicker as opposed to swelling. You can have irritation of the bursa, and so there's a bursa that is right behind the tendon in here, because bursa tissue, like in the shoulder, it's normal tissue that we think it's there to reduce friction between surfaces, and just like in the shoulder, oftentimes you can have tendinitis with the bursitis. Bone spur or apophysitis. So the bone spur is down near the bottom of the tendon. If the pulling action on that causes enough irritation where the bone is, then it can create a spur from the force of pulling on the bone. And apophysitis is a very technical term. Youngsters might get this condition where it tends to pull the bone away a little bit as they're in their growing years. Seaver's disease is this term used for adolescents, youngsters that have this condition where the tendon's really pulling on the bone part of it. You have the same kind of condition in the knee called Osgood-Schlatter's. These are a couple of conditions that are truly growing pain things that oftentimes it takes time for them to grow out for that piece of bone to mature for that. But that can be an area of pain in there. Referred pain, which is, I'm just going to use that term as it relates to pain from a trigger point, or you can have a combination. So that's our job, is to figure that out. So some of the characteristics of the tendinopathy, local tenderness. So if you squeeze the tendon, is that really tender right there where you're feeling the pain? And so we usually check the other person's side first, because if you squeeze anything hard enough, it can be sensitive. So it's in a comparison. So is it really locally tender there, or it's like, nah, that doesn't bother at all? Is it swelling versus the thickening that we just mentioned? It's usually painful to push off. So people that really have, that person that came back from Boston, the next day they're kind of walking around a little flat-footed because to really push off on their foot hurts. And it's often stiff with the initial steps, and it can be even sharp when it's really in the acute condition. So the muscular trigger point. The trigger point is a taut band of muscle, a taut band in a muscle that's tender to palpate, meaning tender to touch, and it gives rise to pain that has a characteristic referral pattern distant from the point. So it means it's very common for most of us to have some soreness up in this section here. So if anyone's had, oh gosh, this is sore, and you poke on it, it's like, oh, that's really sore to touch. And but you know, if I press it a little bit and kind of hold it there, it's a little sore, but it kind of feels good. That's an example of a trigger point. It's very common that we would have. And it can stimulate some other things that relate to circulation and sweating and swelling. So 4 muscles in particular, we'll just look at what those are. tonight, the tibialis posterior, the soleus, and the gastrocnemius are the two main muscles in the calf, and the quadratus plant. So this is the posterior tibialis. Now, if you look at this from the back of the person, the muscle itself, this is right up against the bone, both of the two lower bones in the leg. So this muscle is really, really deep, and it comes down, and the tendon part of it comes all the way across the inside of the ankle, all the way across the foot. So it goes all the way under and across. The red area represents where it's mostly painful when this muscle has a trigger point. It's right on the Achilles tendon. So if in the examination you go and you squeeze the tendon, it's like, well, yeah, it's a little tender, but it's not that bad. That might be one indication that maybe it's not Achilles tendonitis that's the problem. Maybe it's a different muscle problem. So an example of having to really deal with the right issue, or an example of a common problem that might be one of those that never got better, or didn't get better, or didn't get all the way better. So this is trigger point dry needling is the treatment aspect, or one of the treatment aspects to deal with a trigger point. And it's use of a solid filament needle, the same kind of needles that are used in acupuncture, that is used to stimulate the trigger point. So the needles themselves can be very accurate and deeper, and also being metal may also have another element to it that is a different tool than digging in with your fingers, or a variety of other different techniques that might be used to try to affect this. And so that's what we do here in those cases that it's appropriate. So let's look at the other major area we're talking about tonight, of plantar fasciitis. So formally, it's really considered irritation of the plantar fascia. That's actually an anatomical thing. But really, the term is used very commonly with pain either in the heel or in the bottom of the foot. So it's kind of a generalized term. Commonly causes sharp pain on the first steps in the morning. The intensity typically decreases to a dull ache after you get moving on it. But it returns after sustained periods of time of standing or walking. Or if you've been sitting for a little bit and you're going to get back up, it's like, it's there again. Anybody in here have ankle or foot pain problems? A couple? Okay. Good. Well, if we don't answer the questions during the thing, I'm certainly happy to talk with you afterwards as well. So, sources of pain for plantar fasciitis. It can be a strain to the plantar fascia, which I'll show you where that is. It can be a bruise on the heel bone. So the bottom of the heel. There's also a fat pad down here. It can be a bruise to the fat pad. There's also a couple of small nerves that can get impinged on. It can be referred pain from muscle or trigger point. It can be a bone spur, which is a different location of a bone spur, or a combination of those. So those are the things that we have to really figure out and understand. So what is it? And really treat that thing and not treat everything that might not be part of the problem. So looking at the bottom of the foot, the big toe here, so here is just an example of the plantar fascia as it comes across the bottom of the foot, and a couple of the nerve endings that come across there. So it attaches back here on the heel bone. You can see the fat pad is back here. And that's the bottom part. So longitudinal arch. So from the Mayo Clinic website, just not picking on the Mayo Clinic, it's just what they might talk about. The medication piece that we talked about. They mentioned physical therapy, where you might learn some stretching exercises, or they might do some taping. We actually do a lot more than that, but that's the way they mentioned that. A night splint. People that have pain in their heel or arch, sometimes they're put into a boot at night as part of the treatment for this, to try to keep it so that it's more comfortable when you first get up in the morning. And for some people, that's helpful. You can imagine that's not going to be very pleasant to be sleeping with this big boot on at night, but in some cases, that can be helpful. Orthotics may be helpful. Steroid injection, the risk we mentioned. They even mentioned extracorporeal shockwave therapy, which I've really not heard anyone have around here, but it's mentioned on the website. Surgery, which again here gets to be a salvage situation, and then the self-help of icing, stretching, proper shoes, activity modifications, and a lot of these websites mention about weight, so I think it's maybe the common sense thing. If you're heavy and you lose some weight, that'll reduce the load on it. But I'm not sure that I've seen any research that actually says heavier people have more of a chance of getting this than light people, because we see a lot of people who are very thin that have the condition. So here's a trigger point for the gastrocnemius being the outermost, the big bulky muscle in the back of the calf. And so you see this trigger point in that muscle, that's where most of the pain shows up. So if you have pain in your arch, it could be a few different things, but it may not be the plantar fascia, it may be this muscle. So again, it might be different if you're using dry needling on that muscle as a treatment as opposed to trying to rub a tennis ball down here and wondering why is it not getting better. The website says put ice on it, use a tennis ball. So that might be one of the reasons. This muscle is underneath the outermost calf muscle. It's called the soleus. So this one does not cross the knee joint like the gastrocnemius, but it's still a big, long muscle, and it blends into the Achilles tendon as well. And the trigger point in that one section, well, look at that. You have a lot of the pain shows up in the Achilles tendon, and a lot of it shows up in the heel. So there's another potential source for pain down there. This is the quadratus plantae. So this muscle is pretty deep, and that's where this shows up. So people that might think, I have a bruise to my fat pad of my foot, and that's what that's what I've got. Well, maybe that's not what they have. If you inject things, if you inject medication into that area around the fat pad, one of the side effects is the fat pad can shrink a little bit, which is not necessarily going to be beneficial. All right, so let's look at the things related to the biomechanics of it. So the body needs to dissipate loads and forces, and the more uniform the tissue is, the more it'll distribute the forces more evenly. Non-uniform tissues result in a stress riser, kind of a engineering term for steep changes between one thing and another. And that can result to more increased tendency of strain, pain, or injury. So for us, the important idea is relatively more flexible tissue will tend to give sooner or more than relatively stiffer tissue will. So those are the things we're going to look qualitatively. And when we look at things like flexibility, we're going to look at, through all the muscle groups from the spine down that are key muscle groups, are they kind of evenly flexible or evenly tight? Or somebody have an area where, gosh, the hamstrings are really tight here, the calf muscles are really loose there, or vice versa, or left to right, are things really different. So let's look at pronation and supination, and then we'll talk about how this relates to the relative tightness. So pronation would be the movement of the arch collapsing. So as you step forward and the arch flattens, my hand was the arch and it's flattening out, that movement in that direction is pronation. As the arch comes back up like this, that direction is supination. So foot supinates, what pronates. And it takes place through the midfoot and even the rear foot, different parts of that. We're not worried about the technical part of that in this talk. It's normal to have motions of pronation and supination. And the problem is if we have excessive amounts or unlimited amounts, or that they come and go with poor timing. The interesting part about the pronation in the foot is that as the arch collapses and drops when we put our weight on it, the leg bone, the lower leg, also will rotate. And that'll rotate and it'll also have an effect on the whole leg. So while it may not be a big motion you might see, it's an important motion that won't occur one way and then the other, so that motions in the foot are related through the leg. So when we look at things and we look at people, we're going to look at the tightness from really their waist down through their hips, their legs, into their feet. We're not going to come in and say, gosh, I have pain in my heel, and we're going to look at just the calf muscle. Because it may be stuff farther up that really influences what's happening down at the foot. So here it looks like from the back, the two pictures on the right, top and bottom, are normal alignment. The two pictures on the left, you can see the foot is pronated, and you can see what happens to the back. There's your Achilles tendon looking like it's a bow shape. And if you look at the front of the person's foot, same thing. There's a little bit, where the forefoot looks like it stands out to the side. So if you walk on the sand, here you go, your footprints might look different. So we think of this as a person who their arch collapses so much that they have this big imprint. The person that's normal looks more like this, and the person that we call supinated means their arch doesn't really pronate or collapse as much as it should, and it really stays up in the air, so the foot's really not doing its normal amount of collapsing. So, correcting the faulty biomechanics, if we have overstretched tissue, then we're going to want to support it. So, taping or orthotics are two different things that we might do to support tissue that's been overstretched to give it a chance to heal and calm down. In the case of a person who has a foot that doesn't pronate as much as it's supposed to, it's a stiff foot. We may need to manually go in and loosen the joints up because they lack enough mobility, they're stiff. Therapeutic exercise, we're looking at stretching tight tissue only, meaning that if something is already excessively flexible, you don't want to be going to stretch that. You want to stretch that thing that's really tight. And strengthening the weak tissue only, meaning that if it's really not weak and you're spending a lot of energy strengthening it, it may be ineffective. So this is just a picture of what one tape job, there's a variety of different ways of taping the foot, but that follows along supporting the arch. It's called a Lodi tape job, kind of a modified taping. Sometimes this might be a very easy way for us to tell if supporting the area, if that makes an immediate change on the person's pain. And if it does, if they haven't had the pain long, wow, had it for a week, and maybe taping their foot for a few days helps it to calm down and they're in good shape. If they've had the problem a while, and taping the foot really helps. They might be somebody who, an orthotic, that really is something that they can keep in their shoe for a prolonged period of time is a helpful piece. So these are a couple of different pictures of orthotics. So we utilize both kinds here, where this is an off-the-shelf piece, it's ready-made, decent quality, and we find that these kind of orthotics really help the vast majority of people. The one on the right are examples of custom orthotics, which we also do here, where you cast the person and you input a certain supportive materials and design to it that you have a lab manufacture so that it really is very customized. Probably the point I would make here is that it's not at least in our view, would not necessarily be the first thing you jump to if you've had a pain problem, that the first thing is to you must have custom orthotics because your feet pronate. Especially if both feet pronate but only one hurts, is it the custom orthotics that can go from $295 in one clinic here to $450 or more in other clinics. That would not necessarily be the first thing to start at. So manual therapy, joint mobilization is loosening up the tight joints, restoring lost joint play. So when you go to bend your finger has got to be able to move up and down to have some play in order for it to do this. Same thing with the joints in the foot. So what we do is restore the movement between the bones if they're stiff. So there's different sections of the foot, and it's just the stiff area that would get mobilized, not every single piece. So let's look at just a few of the key exercises here. We look at relative flexibility, so stretch all the tight muscles, and don't overstretch the strained muscles. And so we'll look at that in the leg, but a common example, it seems like women more than men oftentimes stretch their hamstrings. So of all the people I see over all the years, women tend to have fairly flexible hamstrings compared to the same number of men. And they, if I ask them what they're doing for stretches, they stretch in those areas frequently. So it can be really common to have very, very flexible hamstrings, and yet other muscles are really tight. So the same thing for the lower leg is that if you have an area that's really flexible, that doesn't mean you should just automatically go and stretch it because the website says to stretch it. But these are some key muscles that we talk about. Sherry mentioned the quadratus and forearm area, which is up here in the flank. Hip flexor muscles that would bring your leg up. The hip rotators, the hamstrings, the ITB, and then the calf muscles being the gastrocnemius and the soleus. So here's one muscle, one stretch that would tend to get this area. So if this area is what's really tight, if you have an area, because you're one side dominant, you shovel dirt all day, things will get short and tighter on one side. It can be tighter here, the hip flexors can get tight, and then the leg actually operates with a torque to it, where it's mildly rotated, which you wouldn't necessarily see it in somebody walking down the street. We'd see it because that's what we're trained to look at. But that would be an example of how things get tight and why is this really important to the foot. So this would be one stretch where the person is really opening up and lengthening that tissue through there. This would be a hip flexor stretch, so the muscle in the front of the thigh, through here it goes, and actually some attaches to the spine, some attaches to the pelvis, and comes down and attaches to the front of the person's thigh. So that would be one element of a hip flexor stretch. The hip rotators in the butt, if they're tight on one side with some other muscles, they may contribute to why does one foot act up and become painful while the other one doesn't. So we're going to look at those. This is another technique for stretching the hip rotators. The hamstring muscle. So one technique for stretching the hamstrings. And then here's a stretch for the calf muscle. A really important concept with stretching the calf muscle, especially with these conditions in the Achilles tendon or the plantar fascia, is that the alignment that the person has with their foot and ankle is really key about this stretch. We talked about relative flexibility. So if you have somebody who they go and they demonstrate their stretch, and it doesn't really appear like if that tight, they can really go pretty far. And what you notice is that their ankle, is that their arch really collapses a lot when they go and do that stretch. Relative flexibility, it's their arch that's really giving way a lot more than the calf muscle is. And if we get very particular about how do you line yourself up when you do that. If when you line yourself up, you make sure that as you lean forward, you don't let your arch collapse, then the person doesn't go as far before they feel the pull in their calf muscle. And so when I have people learn that, and there's a big difference, it's like, great. So now let's put your ankle in the position so that your arch doesn't collapse when you do this. And now do it. Oh, I feel a lot more in my calf now, and I don't go so far. And then I say, great, now let your leg collapse the way you normally do it. And their arch collapses, and they go a lot farther, and they go, oh yeah, I don't feel that in my calf anymore. So the way that this exercise is done is really, can be very critical about whether you're really stretching the stuff that's tight, or if you're really stretching the stuff underneath the arch that if it's already overstretched, you got a problem. So, just a picture with the wrong terminology at the top. Just looking at from the back, this person's foot is collapsed a lot towards the inside. And you can see their foot out there. So this is more of a neutral or midline position if they're going to stretch their calf. Keeping that position, this is where they let it collapse. I don't know if you can appreciate that. That's what I was mentioning there. It's kind of collapsed. There's more. This is a composite stretch that can be really useful for the right people in the right situation. But it's not for everyone. For strengthening, we're just going to touch base on one exercise that's very common with either of these conditions. Heel raising, there's one different terms, heel raise eccentrics. It's really heel lowering. So the person goes up on the ball of their feet, and then they lower themselves down so the heel drops below the stair. So literature has really shown that people that have these long-standing Achilles tendon pain problems, where it's really a tendinopathy, it's a chronic condition, that heel lowering exercises end up being very helpful for this group of people. And so that's important to know, and it's on the websites and very, very useful. A couple of things about it. If you have the acute condition and you're going to do this, you may really irritate the condition. And the other thing is that when you do it, if you also have some other problems that really are going on, and as you let your heel down, your arch is collapsing, then you're really stretching the inside part of the under part of the foot out. Manual therapy, just briefly, a variety of different things. Massage, deep tissue massage, myotherapy, myofascial release, ART, which is active release therapy, Graston technique, which is where people use metal utensils to dig into the tissue. This doesn't sound like physical terrorists, so I'm not sure what doesn't. A-stim. So there's a variety of manual techniques that are used to help release tight tissue and stimulate circulation. The trigger point dry needling we've talked about. And metatarsалgia we're going to save for another day, which is... So, bottom line, treatment's most effective when the diagnosis is specific and accurate, addressing only those things that contribute to the problem, treat the right sequence, and treat the right magnitude. Thanks very much. Is there any questions? I'm happy to take them now. Sure.
If you have orthotics, is that something, I mean, how do you know when to stop using them or do you not stop using them?
Oh, that's a good question. How long do you use orthotics and when do you start or stop, when do you stop using them, if you do stop? That would typically be, I would say, the professional you work with would help answer that for you, because in some cases, it would be a temporary case where just calming the tissue down, if that was really what was needed, and you don't have a permanent problem, then it would be a temporary period, maybe related to the symptoms. But the person you're working with really should be the one that best answer that. Typically, if you have a permanent orthotic, those are usually meant to be used forever. Yes?
I was wondering, there's a German shoe that has a different, I guess, support system. I don't know the name of it, but sometimes it's advertised with native tribes in Africa walk on the same. And I've never really understood the mechanics of that, of getting a healthy foot, so-called achieving a healthy foot.
Are you talking about the kind of the very low profile sandals, like
Yeah.
Birkenstock?
Yeah, yes.
Oh, yeah. Birkenstocks have, they have arch supports built into them, including a metatarsal arch, so they're generally supportive and, to that extent, have a basically good design for a broad group of people. There are some people that may not feel comfortable with those, but in general, it's a pretty good design for the vast majority of people.
Could the chronic use of orthotics or really supportive shoes lead to over-reliance, so you get a weakening of the muscles in the foot?
Well, we could talk about that for about.
Okay.
No, that's a great question, and I only mention it because it's a bit controversial right now about, hey, should people have these shoes? Do they cause problems for us? And there's quite a spectrum of comment on whether or not less support is really better. Is there such a thing as too much support? And I think that there is issues where some people have more support than may be necessary. The other extreme, it is also, I don't think, is not true, where no support is going to cause everyone to get really strong feet and normal feet. I don't think that's true either. So it is a variety, and if anything, it really speaks to the individuality of it. And there's a few editorials that I have here that really speak to that, about it, which, again, it's really a very individualized thing. I would say that some activity where your foot isn't as supportive does encourage you to use certain muscles in your foot that if you're just in this big supportive shoe all the time, you wouldn't use it. So I think in concept there's benefit to getting some activity without as much support, but not the extreme. And I'm happy to talk with you further afterwards if you'd like to. Yes?
So, my wife has what's been called chronic fasciitis, and it's come and gone over the years, no acute injury. How many times should she stay with PCP, and for how long each episode before, hey, we need to pump it up a notch?
I think that ends up being kind of the personal comfort level. Myself is, if you have something and you look up on the web and you do some of the basic things, and if after a few weeks it's getting better, as Dr. Nutting's saying, hey, it's getting better. Oh, well, we'll keep doing the same stuff because it's getting better, fine. But if it just only gets partially better, it's like, gosh, this doesn't mean you have to live with that. That to me would be one indicator about, great, let me get some professional help on this because the basic stuff isn't working anymore, or only worked a certain amount. And if it's one of those things where, well, it was there for a month, went away, but every few months or every year now I keep getting it back, I would think that would be another good indicator about, well, wait a minute, maybe there's something missing here that we could be doing that you could keep that, really fully corrected. So, did that answer your question? Okay. Yes?
What is the treatment if you have bone spurs?
Well, that's a great question. Many people have bone spurs that have no pain at all. So the bone spur itself doesn't tell you that you have something that should be removed or dealt with, because it may not be, that's it may not be the cause of the pain, and probably to a high percentage it's not, because so many people have bone spurs that have no pain. So again, it goes to really understanding, well, what is the source of the pain? Is the bone spur the source, or is it really something else? And, there are certainly a lot of other treatments that can be done before, if it gets ruled out, like, oh, it is the bone spur. Good. Folks, thank you all for coming. If anybody has any other questions at the end,